Paul, we are live on Facebook.
Okay, good afternoon. Thank you all for joining us. I'm Paul Gullickson, Communications Manager for the County of Sonoma, and this is our COVID-19 update for Wednesday, December 9th. As usual, we'd like to start with a brief message for our Spanish-speaking viewers. Gilbert?
Gracias, Paul. Buenas tardes y bienvenidos a la sesión informativa donde la doctora Mase nos dará una actualización sobre el coronavirus. Esta actualización se está transmitiendo en vivo por nuestro canal de YouTube con la interpretación al español. Para escuchar la versión en español, puede usar el link de YouTube que se encuentra en la página de Facebook del Condado de Sonoma. Gracias. Back to you, Paul.
Great. Thank you, Gilbert. We'd like to remind you that this is our usual Wednesday community-wide briefing, and this is a time when we invite the public to ask questions for our panelists. So we encourage you to submit questions either by emailing them to us at publicaffairs@sonoma-county.org. That's publicaffairs@sonoma-county.org. or by just leaving your question in the comments area at the bottom of this Facebook Live page. We also ask for all those who will be joining us as panelists to please speak slowly and loudly for the sake of our interpreters. So let's begin with a brief presentation by Dr. Sundari Mase, Health Officer for Sonoma County. Dr. Mase?
Great, thank you so much, Paul, and thank you everyone for joining us today. Sonoma County remains in the purple tier within California's blueprint for a safer economy. Our adjusted rate of new daily cases per 100,000 population is 17.9, which is more than double last week's adjusted rate of 8.8. The county testing positivity rate is now at 5.7%. Similarly, this is nearly double last week's test positivity of 3.3%. For the first time since early November, the state has updated our equity metric to 8.2%. This is the first time that the state has updated this metric since November. Finally, the Bay Area's regional ICU bed availability is now down to 20.9%. This is down from more than 25% just a few days ago. So as you can see, our numbers are climbing in almost every area, which is very concerning. For now, our region remains above the 15% threshold that triggers the regional stay-at-home order, and we have not chosen as yet to join the 5 other Bay Area counties and Berkeley City in preemptively adopting a stay-at-home order, but we remain concerned about these increasing numbers and remain very much in a wait-and-see situation. Our status is day-to-day, and we'll make changes as new information arrives. The good news is that there's something everyone can do to help us avoid the worst outcomes associated with these increases in case rates and test positivity. You can wear your face covering, avoid gatherings socially, maintain physical distancing with non-household members. So we can identify and safely isolate cases. We also urge you to get tested, which is why we continue to provide more opportunities for free testing. Yesterday, we announced the opening of the Petaluma OptumServe site at the Petaluma Fairgrounds. The site opens tomorrow at 8 a.m. From then on, it'll be open Monday through Friday from 7 a.m. to 7 p.m. and will provide up to 330 testing opportunities for residents in South Sonoma County daily. This will be the 3rd OptumServe site in Sonoma County, and I want to point out that we're fortunate to be only one of 4 counties in the state to have as many testing opportunities available to residents through OptumServe. Only Los Angeles County and Riverside County have more OptumServe sites and opportunities for testing through the state. So with that, I'd like to share with you some slides that I showed during a presentation that I made to the Board of Supervisors concerning the latest information we have about COVID-19 strategies, testing, vaccines, and other information. Let me pull up my screen to share the slides. So I'd like to go through our cases, showing that we have indeed had many more cases over the past few weeks. And like most of California, this is considered a surge. We do have 19.4 new cases per 100,000 residents per day now. Again, we have a peak. The good news is we are testing a lot. We're conducting an average of close to 2,600 tests per day, or 517 tests per 100,000 residents per day. And with the further enhanced OptumServe expansion, we will be able to test even more people. That is, we have a new Petaluma site, and we've added one lane to the Santa Rosa OptumServe site. Our testing volume is now at double that of the state average. And for the last Blueprint tier assignment, we did use a factor of 0.5 to adjust for all the additional testing we're doing. That's from last week. Overall testing positivity at the last tier assignment was 3.3%. So where are all these tests occurring? So of all of our tests that have been performed, 32% were processed by our hospitals, Kaiser, Sutter, St. Joseph Memorial. 19% were processed by us through public health nursing. This is through our pop-ups and our contact testing. 19% were processed through the OptumServe sites that the state provides us. 3% were processed by UCSF. We are no longer using UCSF for laboratory testing, but this was back in during summer. 5% were conducted by our federally qualified health center. And these labs were processed by our public health lab, but also by other private labs that the FQHCs use. 21% were processed by other private labs. And as I've mentioned, we do have numerous private labs that are testing in our county, and we're trying to get them all on board with reporting online so that we can count all those tests. The average testing turnaround time has been really good. As you can see, all of these different labs have a turnaround time of somewhere between 0.5 to 3.4 days. And our public health lab has a turnaround time of about 2 days. There are a few outliers in terms of the turnaround times, but then on average, our testing turnaround time is really good, under 72 hours and under 48 hours in many instances. Hospitalizations are now trending upwards, as you can see here, and they're not as high as they were in July or August during summer when we were having the outbreaks in our skilled nursing facilities and residential care facilities for the elderly, but they are again trending upwards, which is of concern. Currently, this is as of the board presentation, we had 43 COVID-19 positive patients in hospitals and a little bit more than a quarter of them in the ICU. The staffing ICU bed availability has been fluctuating, but was 21% on the 7th, 14% 6th, 11% on the 5th, and I believe we're back down to 11% in Sonoma as of today. And about a quarter of our patients in the ICU are COVID positive. We have not needed to utilize our hospital surge capacity yet, and currently we do have sufficient surge beds, 264 total beds, and equipment in terms of personal protective equipment and other equipment. And we are communicating regularly with our hospital and state partners and all of our healthcare partners to monitor that situation. Gatherings are accounting for a lot of our cases. Again, you can see gathering cases, that is cases occurring from gatherings, increased and are over 15% of our cases in early November. Halloween gatherings impacted that. And we've also seen an increase in cases associated with family and friend gatherings and parties, and we're continuing to monitor the situation. We have our COVID-19 information hotline, which has really seen a dramatic increase in calls, over 20,000 calls received during the month of November. And this is because we started our enhanced pop-up testing in October 19th. And since that time, we've gotten a lot of calls for scheduling for pop-up testing. In fact, the average number of calls logged per day was 349, the highest count being close to 600 and the lowest around 250. So what we've done is we've rolled out an online scheduling system that's decreased the number of calls coming in to persons who are answering the calls through the hotline. So we do estimate that we're going to need more hotline operators to maintain this program through March. Our alternate care site, that is where people can go to isolate or quarantine, has served 414 individuals in Healdsburg. And we've had 78 contacts, 173 COVID positive individuals, and 163 people who are pending their evaluations at the alternate care site. And we are securing additional hotel rooms for people to isolate and quarantine. We have also given rental assistance to 302 people in the total amount of $870,000. And we have served 91 people through the legal aid eviction defense assistance program. A total amount spent $40,000. And you can see here the total amount then spent is $910,000 through our rental assistance program. The COVID vaccine is coming. In fact, we're going to have our first doses of the Pfizer vaccine next week. And the vaccine distribution plan has been submitted to the Department of Public Health, the California Department of Public Health, December 1st. We are going to be following an equitable vaccine allocation framework according to ethical considerations. Healthcare workers who are taking care of patients, that is frontline healthcare workers, and long-term care facility residents. We are identifying and recruiting COVID-19 vaccination providers, supporting the distribution of vaccine in a phased manner, according to the allocation framework that's been set forth based on national and state guidelines. We're conducting outreach and education. We're training enrolled providers on proper vaccine management. And we're building vaccine confidence and trust within Sonoma County communities. And we will gather and monitor the data and the vaccination administration and provider enrollment data. What we know so far about the vaccine is that there are two candidates, Pfizer and Moderna, and these vaccines will be supplied through an emergency use authorization. So people can consent to vaccination. We cannot mandate the vaccination. Both have approximately 95% efficacy, and both come in a 2-dose series. The Pfizer vaccine is 21 days apart between doses, and the Moderna vaccine 28 days apart between doses. Both are mRNA vaccines, and they basically use the SARS-CoV-2 viral protein as a target. And as any vaccine, the immune system sort of gets a preview of the virus and then builds immunity towards the virus. And the only caveat is a Pfizer vaccine must be stored at ultra low temperatures. And we are identifying different free healthcare facilities that have these low temperature freezers, and we have them with public health as well. Moderna can be stored at a standard frozen temperature, allowing for many more healthcare facilities to store that vaccine. So CDPH is, that is the California Department of Public Health, is coordinating vaccine distribution through local health departments and our large health systems. Local providers are registering with the state to request, receive, and track vaccine doses. The Department of Health Services is working to identify and recruit vaccination sites for phase 1. And we're also working on procuring access to the ultra low temperature freezers to provide increased vaccine storage capacity for our partners who don't have access to these freezers. You can find out more about the vaccine at socoemergency.org. There's a whole page that's committed to that. And I highly recommend that when your category or tier is going to be vaccinated, that everybody get vaccinated. It's a very effective vaccine and has been very safe to date in all of the trials that have been done so far. So I'll stop there and we can take questions, Paul.
Great, thank you, Dr. Mase. Yeah, so this is a chance. Now we'll go to questions from the public and our media partners. First, let's take a couple of questions from the public. Dr. Mase, there's a number of our listeners who have many concerns about whether or when we're going to go into a stay-at-home order. Judy speaks for many of our questioners today. She says, I live in the city of Sonoma, and I am growing increasingly concerned that our county has been seeing and will see an influx of people from the other counties that are under a stricter stay-at-home order. It seems to me that if only Napa and Sonoma counties are more open than our neighbors, our rate of COVID infections will grow exponentially. she's encouraging us to move into a more restrictive stay-at-home order. And there's a number of others wondering if and when we might be at a stay-at-home order given our the rising case rate. Would you like to talk about that?
Yeah, thank you for that question. I think it's a very important question. We are closely monitoring all the metrics that would include hospitalization, bed capacity, the actual case numbers that we're seeing, and are considering just the things that you're considering. We are trying to figure out when would be a good time for us potentially to go to more restrictive measures. We're discussing it with our surrounding counties that have not gone towards restrictive measures, such as Napa and Solano, and share your concerns. So we will keep you updated on this. And as you know, when the entire region of the Bay Area goes to under 15% ICU bed capacity, the state will move forward with that regional stay-at-home order.
Well, on that note, that's a good segue to our next question, because there are a lot of questions about the confusion about, we know that the Bay Area ICU bed capacity is at 20.9% today, but there are questions about what is our current percentage of ICU beds in hospitals right now.
Let me turn that over to Kate to respond to that.
Hi there. So on the state website, they have a map where you can look at the percentage for the region as well as the percentage by county. I believe our percentage today is, and Paul, you may have that in front of you, I believe it's about 11.6% or so for capacity in Sonoma County.
That's right. It's 11.6% for Sonoma County. They have us listed at this point. So thank you, Kate. For those who don't know, Kate Pack is our health program manager for Sonoma County's epidemiological team, and we appreciate her. She's the guru of all things data related. So thank you, Kate. Let's go to some of our media partners. Let's start with Julie Johnson from the Press Democrat. Julie.
Hi, thank you so much. I also wanted to ask about the possibility of a shutdown and what your thinking is on that. You've said, we're going to follow the numbers, we're monitoring the metrics, and with our ICU bed availability low compared to the region and lower than that 15% threshold from the state, I'm wondering what metrics you are looking at to explain your feeling that we can wait.
Yeah, I think, the ICU bed availability metric is based on the staffed existing beds. We also do have surge capacity, both for that and hospital beds. So we're looking at hospitalizations, our case numbers and rates, as well as ICU bed availability metric. And we're, as you just noted, we're monitoring all that closely to see when it would make sense for us potentially to move to a more restrictive stay-at-home measures like some of the other counties have done in the Bay Area.
If I can ask a follow-up, when it makes sense, can you say a little bit more about what those factors are? Because I know it's not just case data, I imagine, but please correct me, you're thinking about economic impacts, you're thinking about equity impacts, you're thinking about the big picture of public health is what I imagine. But I'm wondering from where you sit, and I think, from the public's perspective, it's confusing to have our ICU bed capacity so low, but we're not taking the action of other counties. So I want you to explain a little bit more about why you're willing to wait.
Yeah, thanks for that. So we are looking at all the different impacts. And what we're most worried about is exceeding the healthcare system. It's a sort of a ability, obviously, to take care of our community. And we are not at this time seeing large increases in hospitalizations. We do have some increase in hospitalizations, but we've got a little bit of leeway yet. And the ICU bed capacity metric is one of many of the different parameters we're looking at. We're also looking at the economics and, what it would mean in terms of a shutdown to our business community. So there's different things that weigh in on this. The other thing to note is that we, being a smaller county with not as many ICU beds, let's say, for example, San Francisco and Santa Clara and all, also quickly reached that under 15% ICU bed availability because of the low number of beds we have to start off with. And we're also talking to our hospitals to see when they think they are in a place where they're really concerned. I've had discussions with every one of our hospitals, and at this time they feel like they have the capacity and they're not quite there yet where they're extremely concerned.
And quick follow-up, what about staffing to up our ICU beds? You talked about PPE and ventilators and other equipment, but do we have the people to add to our ICU bed capacity?
Yeah, from my discussion with the hospitals, it seems like they have enough staffing for the ICU beds. I'm not hearing that there's a crunch. And that's exactly one of the things that we're discussing with the hospitals is see when we would need to go to more restrictive measures, is staffing.
Okay, thank you.
Dr. Mase, I want to jump over to some questions from the public. They wanted some simple definitions. One, if you could explain what is a surge bed. That was a question that the public had. And also, if you could draw a distinction between a staffed bed and a licensed bed. What is the difference between those two?
Okay, so a surge bed, whether it's a hospital, general hospital bed or an ICU bed, is a bed that right now doesn't exist in the hospital. It's not a licensed bed that's already there, but they can add, hospitals have a plan where they can add, say, 1/3 more capacity if needed. In other words, if the hospital is filling up, they can say, okay, we're gonna open up this entire new wing and add this many beds. So that's a surge bed. As far as staffed versus licensed beds, so let's just say that one of our hospitals has 20 total licensed beds at this time. In other words, those beds exist right now. They're not surge beds. They exist now, but they only have, let's say, 3 people in the ICU at the time. They may have staffing available right away to call people in for another 7 beds, meaning that their staffed beds would be 10, but then their licensed beds are actually 20. And I know that, Kate or Dr. Baldwin also have a good handle of this question. I don't know if you want to add anything.
I was actually going to recommend either Brian Cleaver or Carly Sullivan from EMS or James. They monitor this.
That would be great.
In it, they could answer it.
Hi, Dr. Mase, Brian Cleaver from EMS, and I can take the first sort of explanation at that. So I think you really kind of hit the nail on the head with your example. Hospital A has 20 licensed beds, but if there were only 3 ICU patients in there, they wouldn't staff all 20 beds. They certainly would only staff the 3 that have existing patients and maybe 1 or 2 more to be prepared should additional patients need to be admitted to the ICU. Oftentimes, the staffing resources that would be committed to those other beds can be utilized in other areas of the hospital that also have patients. But should you see a surge and those 3 beds now move to 7, you're absolutely right. They can use the in-house resources to shift back to the ICU to keep that surge covered. And of course, to speak to Dr. Baldwin's comment about monitoring, yes, that is something that's a regular part of our monitoring multiple times each day is truly watching, because they are dynamic numbers and they do change oftentimes hour to hour. And so, we do try to monitor them multiple times throughout the day. Does that answer the question?
That's great, Brian. I want to mention Brian Cleaver is our regional medical services. He's the regional director for our regional medical services authority, and we appreciate him being on here to help us today. Thank you, Brian.
Thanks, Paul.
Let's go to Susan Walbarst. Susan, you have a question?
Yes, thank you. I've been reading about some side effects caused by the vaccine, which include anaphylactic shock type reactions from people that have allergies. And I just wondered if you had any comment on that.
I think I'll have Dr. Baldwin, who's sort of leading our vaccine effort, answer that.
Hi, Susan. That's a good question, and I'm sure that you're not the only one who's concerned about that in the community. The trials, the data that I've seen so far from the trials that the Moderna and Pfizer have done with their vaccine didn't show anaphylactic reactions as a I'm not sure if any of the people in those trials actually had that reaction. And if so, it was very, very few. However, I did see in the news recently that I think 2 people who may have gotten one of these vaccines had an anaphylactic reaction, or they say they did. I don't know the details, so I don't know if that's actually what happened versus something else happened. So I don't know if I can really comment on those 2 cases. Just to let you know, though, that can happen with any vaccine. And there are people, many people who have reactions, bad reactions to, say, penicillin. And that's a very common antibiotic that's given, but you still, it's still useful. There's a lot of people who can still get it. And in certain populations, if they've had those reactions and that's the only medication for them, there's ways to treat it and get them through it. So it's not an unusual thing. Let's put it that way. It's a risk for all the vaccines that are out there now that we're all used to. And it will be something that will, the state and the county and the federal government will be monitoring as vaccine is being administered throughout the counties, throughout the United States.
And Dr. Baldwin, I do know there was a story today about how in Great Britain, health officials were encouraging those who caution for those to take the vaccine who have a significant history of allergic reaction. And I think very much along the lines of what you were just saying.
I would really consult with your primary care provider if you have a concern about it, or if you've got any history of severe allergic reactions or anything like that. That's definitely something to talk to them about before actually getting the vaccine.
So on that note, we have a couple of other questions related to vaccines. One question from Rick is, do we know how long the vaccine is good for? And how long it will last. Dr. Baldwin, do you have thoughts on that?
I think what's being asked is how long do you have immunity after getting the vaccine? I think that's
correct.
That's
That's a good way of phrasing it.
That's another great question. And nobody knows yet, because even the people who were in the trials, the clinical trials, they haven't even gotten that vaccine a year ago, most of them. So we don't know. And they'll be continued to monitor and well past the trials haven't ended. Let's put it that way. They will continue to be monitored to see how long their immunity lasts. And that'll be also something that, as people are getting the vaccine in the community, something that will be monitored as well. But we don't have an answer to that yet.
Great, thank you. And there was a question about if we do go to a stay-at-home order, the question is, will vacation rental properties be closed? And will the launch ramp and day use area be closed at Doran Park? I don't know if we have a specific answer for that. I don't know if Adam Radke, our Deputy County Counsel, if he knows that at this point.
Sorry, it was difficult to unmute. If we can come back to that question, I'll take a look at the order.
Okay. I do believe it applies to vacation rentals, but I can't say specifically about outdoor recreational facilities. I believe they still will be open. Indoor recreational facilities will be closed, as well as wineries, bars, and breweries. Yeah, we can. Thank you, Adam, for checking on that. Okay, let's go to Julie Johnson, who has a follow-up. Julie?
Yes, thank you. First, just a quick question. The 11.6% ICU bed capacity, do you know what that is in hard numbers? And does that mean current, I just want to describe it correctly. Does that mean like available beds today, staffed today, but that doesn't represent what we could have?
That's a number that the state has, Julie, and that is in whole terms of staffed ICU beds that are available. And so that's 11.6. They have 11.6 for Sonoma County. So it's basically the same number they're using for all the Bay Area.
Okay, so staffed, not representing licensed.
Correct. Staffed ICU beds.
Okay. And then Dr. Mase, I wanted to ask you two things. First, the San Mateo health officer issued a long statement sort of talking about his reasons for not shutting down. I found him interesting and wanted to know what you thought. He touched on aspects of the state order that he felt were contradictory and not science-based. And something he mentioned was this, what I don't know if faulty is the right word, but this imperfect method being used to evaluate true ICU capacity, what we can handle as a community. I wondered if you share some of those concerns about sort of the standards being used and what your benchmarks are.
Well, as I've just said, Julie, we're looking at our metrics and we are concerned. We're having increased numbers of cases. We're having increased numbers of hospitalizations. And we're also seeing that decreased ICU bed capacity. I think all of these metrics are reasonable for measuring the severity of the impact of COVID at the time in the community. I also think that what the stay-at-home order does is it simply decreases the number of interactions that people have outside of the house. Whether it be going to an outdoor restaurant or whether it be going to a barber salon barbershop or hair salon, or whether it be, going to the grocery store. Simply having that stay-at-home order limits the numbers of interactions people have, and that's why it's effective. And that's what we found to be effective last March, is because we minimize those interactions. It also, by the way, completely prohibits gatherings of any sort outside of the household. For all those reasons, I understand why the state thinks it could be very effective in really shutting down transmission of COVID. And as I said, we are simply tracking our numbers to see when it's appropriate for our own community in our county to go in that direction, whether it's worth waiting until the entire region is under 15% or making our own decision. So that's where we are right now.
Okay, thank you. And just a quick follow-up, because this leads directly into this. Given what you're seeing right now and your understanding of how cases multiply, I'm wondering what projections do you have? What are you thinking? Where are you thinking we might be in January with our cases, given the increase we're seeing right now, the lower ICU bed capacity, all these concerning trends?
Well, like I've said in the past, it's very hard to predict what's going to happen with our numbers over time, because there's so many variables that impact the change in case rates, test positivity, hospitalizations, et cetera. I think we're going to see an increase over this month, as the state has predicted also. You can always go on the state's modeling website to see what the state's predicting based on numerous different models that are out there as to what's going to happen to our cases over time. And all those models do predict an increase in cases over the next month.
So it sounds like you're concerned about what you're seeing, and you think a stay-home order is very effective. And so you're just waiting for the information to tell you we got to do this now?
Basically, I'm monitoring the data along with our healthcare partners, like our hospitals and the Board of Supervisors. Of course, we're looking at the data to see when it makes sense for us to go that direction. Now, a stay-at-home order, of course, is only as good as how well people abide by it. Last March, when the stay-at-home order went into place, people were really good about abiding by the order, which is why it was so successful at flattening that curve. And I would hope to think that if we go that direction again, that people would then abide by the order again so we can really shut down transmission.
Thank you.
And Julie, just a reminder, the way the rate trends are going, we might be below the 15% threshold for the entire Bay Area region very soon anyway. And so we'd certainly be abiding by that. Let's go back to Adam Radke, who has an answer for us concerning the outdoor recreational facilities and rental properties.
Yes. So for short-term vacation rentals, hotels, and the like, the regional stay-at-home order does affect how they are allowed to operate. The state has a very good FAQ online called Under the Regional Stay-at-Home Order, Can Hotels, Vacation Rentals, and Short-Term Lodging Sites Accept Reservations? The answer, just to kind of quickly summarize, is that they are allowed to offer lodging to essential workers, for those who need housing to isolate or quarantine for the homeless population. However, they cannot accept or honor in-state reservations for non-essential travel. And you can find the FAQ on the covid19.ca.gov website, and it will go into a lot more detail.
Okay, great. So it sounds like they'll be under the same limitations as hotels and other lodging. So
correct.
Yeah. Okay, we have another question about testing, and I would perhaps this is for Dr. Mase and perhaps Dr. Baldwin, basically asking, we are continuing to push for testing. Is that still effective at this point? And then we have a couple of questions also about the number of false positives we're getting on testing, if that's a problem. I think there's a misconception about that, but Dr. Mase, do you want to address that?
Yeah, I think testing is still very effective. We want to try to test as many people as possible. We want to be able to continue to have that detect people who are asymptomatic, who are cases, get them isolated so we can do contact investigation and quarantine all those contacts and test them. So that's still very effective. And all counties are still wanting to do that. You know, as I had said yesterday, there is a chance of a false positive test, but given the amount of transmission and cases we're seeing in our community, it's very unlikely to have false positive tests at this time. This is a test that's being used all over the country, all over the state, that has been, we have a lot of experience with it and know that it's a really good test for finding those people who actually have COVID and ruling out COVID in those people who really do not test positive. So I think we should have a lot of confidence in the test this time. I don't know if Dr. Baldwin wants to add anything.
No, I think your answer is pretty much what I would have said. We have not seen any evidence that it's not a good test and very useful tool in the COVID pandemic and trying to make sure that people are identified if they're positive and isolating. So I think we.
Okay, great. Well, we're going to end it here. I just want to thank everyone. I want to thank our crew who helped out today, including Jordy, our Spanish interpreter, and Elizabeth, our ASL interpreter, and all of those behind the scenes. We just want to thank all of you for joining us. We encourage you to like the County of Sonoma Facebook page and follow us on Twitter. It's a great source of information. And in particular, we encourage you to use our socoemergency.org website for information in all of these areas, whether it's related to testing, vaccines, or the data about the spread of COVID in our community. It's a great resource for information. And we, again, invite you to join us next Wednesday for these live briefings at 3:30. Until then, have a good week and stay safe.